Comenzamos con esta segunda instancia de charlas con expertos del Comité de Imagen de la Sociedad Uruguaya de Cardiología. Y bueno, hoy tenemos el agrado de que esté con nosotros al doctor William Zoghbi, que es un distinguido médico cardiólogo, especialista en imagen cardíaca a nivel mundial. Bueno, es presidente, es profesor del Instituto de Houston Methodist Academic, y es presidente del Departamento de Cardiología de dicho instituto. Y bueno, y tiene amplia experiencia, participó durante muchísimos años en la American College of Cardiology, en la American Heart Association y en la American Society of Echocardiography, y donde fue presidente de la ACC y de la ACE. Y bueno, sin más, agradecerle mucho su participación y que haya aceptado la invitación, y empezamos nomás, Cami.
All right, thank you very much. Thank you, Sebastian. And good evening, everyone. I know it's late at your place, but it's late also here. There's just 2 hours difference. First, thank you for the invitation to spend some time with you and share with you some thoughts regarding prosthetic valves. I know you're interested in the topic. Uh, and I was telling, the group here that this is, the guidelines were published, early this year. And this is my first formal presentation for the guidelines to a group of cardiologists, imagers, as well as trainees. So let me share with you the presentation I have for you. Okay, do you see it?
Yes, perfect.
Very good, thank you. All right, so we're gonna look today at pretty much all areas of prosthetic valves, from the types, the approach to evaluation. I want to concentrate mostly on the aortic and mitral valves and look at the comparative roles of advanced imaging, transesophageal, CT, MRI, and PET. I'm not sure which ones are available to you, but even
All
if
of them.
the last three, all of them are, and if all
Yeah.
of them are, I think this is very appropriate.
Yeah.
Well, this is the landscape of prosthetic valves, from mechanical valves, bioprosthetics, stentless, and percutaneous valves. And obviously, this is a challenge for the clinician as well as the imager because there are so many different brand names, different makes. So imaging them is difficult to try to differentiate them, but at least we could put them together in biological versus mechanical valves, in addition to the percutaneous valves, which look different. This talk today is not about management, but I think all of you know that it is a balancing act as to the choice of the prosthesis for a particular patient. There are many factors, as you see here, that would be involved in deciding on a patient of what kind of prosthetic valves do they get. And patient preference is also important, younger age group or older age group, etc., and comorbidities. So all of these are very important. This is the old guideline we're talking about 15 years ago. I was privileged to chair it. That was the first guideline on prosthetic valves. And finally, after about 15 years, there is an update for you. Was published early this year in collaboration with the other societies besides American Society of Echocardiography. We will talk about that mostly, but in addition, I'd like you to also look at another guideline we published about 5 years ago on percutaneous valve repair and valve replacement, mostly evaluating regurgitation. And I think this assessment complements the current guidelines. So for you, I would refer to both of these guidelines in addition to just see what the situation is. First, let's start on some general considerations in prosthetic valves. We always try to assess. These are obviously not normal, not native normal valves. So they have a different structure, and we want to make sure that function is normal. So from a structural point of view, we look at mobility. If there is a valve thrombus or pannus or thickening, if it is a biological valve, any complications. From a functional status, we look at velocity gradients. We try to assess an effective orifice area, and if there is valve regurgitation, we would be looking at that. This is echocardiographic imaging of various prosthetic valves. These are the biological valves in 2D and 3D. It's important to note for you, if you don't know that already, that the size of a prosthesis is actually the sewing ring diameter, is not the actual orifice diameter, which is larger. So if a 21 or 23 millimeter valve, it is not actually the size of the internal size. So geometric area is different also than hemodynamic area. And don't be fooled by the size. So a 19 millimeter valve is really very small and will cause higher gradients. The other thing is, it's important to know what determines velocity and gradients across the prosthesis. Valve size is important, valve type, in addition to the flow rate, so stroke volume, if you will. And for mitral and tricuspid, it's also the heart rate, because this is where diastolic filling period is important, and therefore the velocities as well as gradients in a tachycardic patient, as opposed to a bradycardic patient, will influence gradients and velocities very much. Another important point is, this is from a Doppler evaluation, not from a hemodynamic evaluation, is bileaflet valves are different than biological valves. In the bileaflet valves, between the two leaflets, there is a high velocity gradient, and you could see that by color Doppler. And therefore, when you do a CW, you really cannot differentiate between these velocities. So the number that you get is usually a little bit overestimated compared to what you measure at cardiac catheterization. And this has been known for many years. This is 1990s, Dr. Baumgartner, who looked at that. I know we don't see much Star Edward valves, but importantly, a bileaflet St. Jude valve will overestimate gradients by Doppler compared to cath. And that overestimation may be about 30% or so, is higher at high flow rate and with a smaller valve. Now, in the guidelines, the new one, we have 9 tables for you for a reference as to what the normal valves are in every position, and all kinds of valves, at least up to 2024. There may be some newer ones coming up later. So this is for your reference. Also, when you look at a prosthetic valve, you need some clinical information. The date is important because duration of the valve is important. Type and size, height and weight, symptoms, blood pressure and heart rate, particularly for individuals in the mitral and tricuspid position. So this is the first box in color. The second box is imaging of the valve, and usually our first line is a transthoracic examination, looking at the valve itself, its structure, its mobility, and a Doppler evaluation with, I'm not going to go through every little Doppler evaluation, but there will be spectral and color Doppler to look at flow in addition to any evidence of regurgitation in these valves. And the question comes, now we have advanced imaging with transesophageal, CT, and MRI. Where do they fit? From a transesophageal examination, it has a lot of advantages. Very high spatial and temporal resolution. This is the best modality non-invasively to look at hemodynamics. However, not all valves are seen in the best way. Mitral valves en face is much better than an aortic, tricuspid, and pulmonic. It is probably the best methodology to look at vegetation, small and mobile, because of mobility and time resolution. Regurgitation is very sensitive with this methodology, provided of where you are. It is portable, and there's no issue with renal dysfunction. Now, the limitation is it really depends on the valve. And if I'm in a tricuspid or pulmonic position, the pulmonic is probably the least best visualized compared to a mitral, where you see it en face perpendicular. Reverberations will hinder visualization distally. And what happens with the CT has an excellent spatial resolution. So from a resolution point of view, is probably the best. Good visualization of the occluder, particularly mechanical occluders in any position, which is a major strength. For paravalvular regurgitation and dehiscence, I think it's a good one. Depends also how large it is. If it's a small dehiscence, it may be missed. It is still very useful when you have even multiple prosthetic valves. And you could use non-contrast also for mechanical valve motion, because some of the limitations are obviously renal dysfunction. You do not have hemodynamics with CT, so it's important when you order that. Valve regurgitation is inferred because of either dehiscence, and usually they are larger for you to see them. Beam hardening can interfere with the visualization. And in some individuals, particularly the younger individual, repetitive CT scanning, may be detrimental. Last, in CMR, we can quantitate, similar to Doppler, peak velocity and gradients, particularly in bioprosthetic valves. The strength is regurgitant volume and regurgitant fraction calculation in valves that are regurgitant. You could see anatomic area only in bioprosthetic valves because of artifacts that you could see here on the left upper. And you can identify large perivalvular complications like dehiscence. There's some limitation to spatial and temporal resolution. The artifact can hinder visualization. And this is not the methodology to look for small or mobile vegetations. And rhythm is important, so irregularities of the rhythm may interfere with visualization. So let's talk about aortic and mitral valves per se. For the aortic valve, if you could take a look at the velocity here on the right side and estimate the gradient, the question is this normal or is this abnormal? Because pretty much in all cases, the velocities are higher than a normal valve. Take a look at this publication many years ago from our institution. So remember the determinants of velocity, right? Type and size. So even if I know two of these three factors, look at the spread of the velocities. So even for a 19, 21, 23 millimeter valve, velocities and gradients are quite variable, although we know exactly the, and you would know that this is the influence of flow, right? So if I correct for flow, hopefully that variability decreases. And indeed, if you measure an effective orifice area, similar to aortic stenosis with the same formula, the spread decreases significantly. Still, there is a relation between size from 19 to almost 31 in an aortic position with effective orifice area. So therefore, if you use effective orifice area as a measure, you really need to know what size prosthesis this individual has. Another index, I think, which is very helpful, is a simplification of the continuity equation. It's the ratio of velocity proximal to that through the valve. So the ratio is always less than 1, and normal for surgical valves is greater than 0.25, usually greater than 0.3, 0.4. For a TAVI valve, better hemodynamics most often is about 0.4, 0.5, 0.6, and even higher. And notice the advantage here of a Doppler velocity index. The advantage is less dependent on the prosthetic size. So if you go from 19 to 31, there is a slight increase in that DVI as opposed to the very large increase in effective orifice area, meaning if I don't know what the prosthetic valve size, I can still use it. And if it's getting 0.3 or lower, I would be very concerned about some obstruction of that valve, which would need further evaluation. So when you have an obstructed aortic valve, a few things happen. One, ejection time, as you could see there, the duration of flow increases. Acceleration time also increases from the onset of flow to maximal flow. In AT that you see there, peak velocity also certainly increases and gradient increases. And these are the things that we usually use to assess, valve function. So what would suggest stenosis is a high velocity, higher gradient, a low Doppler velocity index, and effective orifice area, a rounded contour, and acceleration time greater than 100. If you're between normal and this, you suspect conceivably stenosis, and you have to do further evaluation and see what happened over time. There is an entity of prosthesis-patient mismatch. Simplistically, it is too small for the patient demand and flow. So basically, you have a normal valve function, opening and everything else, effective orifice area, yet the gradients are high. And, this is definition below for a prosthetic aortic valve occurs more often in the aortic position as opposed to the mitral. It still occurs in the mitral position, but certainly at larger area. Notice that there is a correction for body mass index because individuals who are obese may not necessarily have more flow. And also, if you divide by a very large body surface area, almost everybody will have prosthesis mismatch, yet they don't have a high gradient. So what is underlined on top, you have to have a high gradient for you to suspect prosthesis mismatch, right? So normal function, normal valve area, but too small for that particular individual. If you had a chance to take a look at the guidelines, this is an algorithm to try to help you understand when you suspect stenosis. You look at the shape, contour, acceleration time, if it is short or long, and if acceleration time over ejection time is greater than 0.37 in a patient who has a high velocity jet greater than 3 meters. We're not going to go through each one of them, but these are available for you to ponder on. And I think the more consistent these observations are, effective orifice area being small, they're consistent there. And if you're wondering about patient prosthesis mismatch, which would be tricky to understand, then you have to do further imaging. And we would suggest, as you see like in gray at the bottom, that radiology, X-ray, is usually better than transesophageal in the aortic position. Why? Because you could see those metallic areas much better than transesophageal echocardiography. Just to show you here that in a TEE, success rate in a mitral position is almost 100%. However, in the aortic, yes, you could see the valve, but the question is, can you see every portion of the valve? How much does the valve open? And, is there a small area of abnormality? That would be very difficult. And I would say that the yield is closer to 20% or 30%. So that you need something much more definitive for you to be able to see that. So you can use fluoroscopy if you still remember how to do that. Very simple, right? But nowadays we're not using it. We use mostly CT. And this is a CT for you. This is CT with an A, meaning angiography. But in the angiography advantage is that you could see if there is a thrombus or pannus, but you could use that in somebody with renal dysfunction. If you have somebody with just normal excursion of the mechanical prosthesis, you're probably less worried about the situation as opposed to others. So, use your judgment. And you could use TEE, but notice what the concern would be, right? Not too diagnostic. You could use MRI, particularly in bioprosthetic valves, but in mechanical valves, there will be too much artifact. In biological valve, you could measure the area, as you could see there if you want. The resolution is not as good as transesophageal, and you could have a gradient. So it depends what the situation you're dealing with. And remember, if I can't get a gradient at all for whatever reason by my transthoracic, very difficult study, transesophageal is not the most accurate test to get a gradient through an aortic valve, although you do a transgastric approach. So an MRI is not a bad idea in those situations, at least if you want to use something non-invasively. Well, TAVI is here, and it is different than surgical valves in many ways. It has a long metallic frame as opposed to the very short, narrow surgical annulus. So therefore, and at the same time, it actually gives very good hemodynamics. You barely have a gradient in these valves, which is very good. However, because the frame extends also variably into the LV outflow tract, the measurements of diameter can be, erratic and may not be consistent and can influence many of the measurements that you have. And whenever you have aortic regurgitation, also it can be difficult to assess severity because of the channels where AR occurs. For those of you in echocardiography, I will, I'd like to show you a few things. One is the usual measurement is just below where the frame is. So the diameter is a little larger than if you measure it inside the frame. However, at times, some of these frames are too long and there's no other way to measure it. But notice that where the pulse sample volume is, you need to be where you are measuring it. If I'm measuring it inside the frame, my pulse Doppler has to be inside. If I measure it just outside, it has to be outside. And why? Because the velocity will change. Now, if you make it, if you measure below, but your pulse sample volume is in, you will overestimate what DVI is and probably effective orifice area also at the same time. So you have to be careful of where you measure it. It won't change your gradient because this is continuous wave Doppler. So the most reproducible is actually the gradient as opposed to your Doppler velocity index or stroke volume. Now, you have to be also concerned about nowadays, these valves are aging longer. When do you get concerned about, some stenosis, some structural abnormalities? If you start having an increase in velocity and gradient, DVI decreasing, effective orifice area decreasing, this is why the importance of serial follow-up of such patients. And this is a patient with this entity of hypoattenuation, of leaflet thickening. You could see them there. They're not as clean. There's thrombi in there and thickening. You could see them there on the leaflets. And after anticoagulation, velocity comes down. And actually, the valve looks much thinner, nicer, more pliable. So I think that's what you want. So in addition to what I told you about, message number one is you need to have a good post-operative examination for you to compare. Remember, these patients are never free of issues down the line. Something will always happen to them, unfortunately, but this is their plight. So you need to have some baseline, after surgery for you to follow. In the mitral arena, few other things here. One is just like mitral stenosis, these valves are smaller, so the velocity is higher than usual. Pressure half time may change, but be careful about pressure half time, meaning the descent of the velocity. Why? Because, these are not normal hearts. So when somebody had a mitral valve replacement, there may be LV dysfunction, LA dysfunction, differences in atrial ventricular coupling. So pressure half time will vary and may not be a good index of function. It starts getting a decent index of function if it is long. If it is short, you cannot use it for measurement of valve area. You could use it as an index if you want to. And use effective orifice area by the continuity equation. You're probably going to need it about 20% of the time or so because pressure half time may be misleading in the other 20%. What do we use? Maximal velocity, mean gradients, importance of heart rate. It can be quite variable. You could have an obstructed valve with a mean gradient of 4 if their heart rate is 50, 55. So you got to be very careful. We talked about pressure half time, not always accurate. Need to know how to use effective orifice area using the continuity equation, stroke volume divided by the VTI. Doppler parameters, these are, the guidelines. They have really not changed from the 2009 because, the indices are still about the same. So if the peak velocity is quite high, mean gradient is quite high, the Doppler velocity index is the inverse of the previous ratio, and there is a reason for that, because it allows you a larger number, because it also can happen in stenosis and regurgitation. We'll talk a bit about it. Effective orifice area and pressure half time. And this is an example for you. This is somebody who has a very high mean gradient 22 at a decent heart rate. Heart rate is not that high, and you could see that the prosthesis is really obstructed, doesn't open well, and you could see here even on the 3D examination that one of the leaflets is opening, the other one is completely closed. And that's the beauty actually of 3D en face view of the mitral valve. You can get it 100% of the time, and you could do multiplanar reconstruction. This is a case of a valve in valve. The prosthesis, you could see here how obstructed it is. That's maximum opening. This is from the ventricular side, mean gradient of 8. Heart rate is low. And then here you go. After a valve in valve, the opening is very nice. The gradient is much better, etc. This is an example where things can go wrong with pressure half time. Mean gradient of 8 at a decent heart rate. So it means either the valve is too small or there's some obstruction. This is your differential in your mind. Pressure half time is short. So there's something wrong here, because if I use continuity equation, I get a valve area of about 0.8, yet this one is telling me that the valve is completely normal, right? And then you could take a look at it. This valve is really very abnormal. So be careful about pressure half time, particularly when the velocity time integral is quite high, 50, 60 and above, and the mean gradient is high. And there's some discordance. So this is how, and that's how you use a continuity equation. Now you cannot be using it if you have concomitant AR or MR. Works best in regular rhythm. Why? Because you're using one side versus another. And if you have atrial fibrillation, it's all over the place. You can get almost any number. So you got to be very careful. And if you have AFib, you have to match RR intervals. And if you're in doubt, you're concerned about regurgitation, then you do a transesophageal echo. Now, this is the same picture that I showed you before to re-emphasize that for the mitral valve is 100%. It's pretty much 100%. You could see everything. And that's the beauty of a transesophageal and the mitral. So this is the first portion of this talk, is talking about structure function. This is from the guideline. It took us almost about a year to put this together. There's a little extension here. And for us to be able to see as to how do you actually compare these valves from an accuracy point of view or feasibility point of view. This is TTE, transesophageal, CT, and MRI. If you look at valve structure and atomic area in bioprosthetic valves, T is excellent, CT is excellent, CMR is still decent, but not as good as the others. So these are your two preferences. Now, in mechanical valves, this is a different issue. For a transesophageal examination is not as good, unless you're dealing with a mitral valve. CT does not matter which valve position you're dealing with. Is if you're looking at just mechanical motion, if there is something obstructing, you're going to see it. MRI, not good. Gradient, transthoracic is probably the best, obviously. But if in the mitral position is still very good in TE. CMR has some issues with gradients. Thrombus, pannus, and the mechanical valve. Transthoracic is really bad. Transesophageal, quite decent in the mitral position. CT is superb, actually, in those situations in mechanical valves, and CMR not good. So keep those in mind when you need some further information from your transthoracic examination, right? So TEE is best for mitral if you're looking for structure. On the aortic position, probably CT. MRI is good for hemodynamics in case you cannot get them from another situation. Now, how about regurgitation? Okay, and this is regurgitation here. I mean, you need to know because with echocardiography, particularly with transesophageal, it's very sensitive to any regurgitation. You could see it there that this is a St. Jude or bileaflet valve. The other valves, you're not seeing them as often. Now, one important thing here is that with echocardiography, there is shadowing, there is flow masking, particularly in the mitral position. Less so in the aortic position, but in the mitral position, if you shadow what you see, you also shadow the Doppler examination. So you're not going to see as well in Doppler. And this is an example for you. Prosthetic mitral and mechanical, right? Now you see a little regurgitation, you can't tell how bad it is, and you'll find out how bad it is. It is torrential. There's a dehiscence of the valve itself, really is bad. So if you are the echocardiographer, this is where you need to suggest for your colleagues that there may be regurgitation that I'm not seeing, and you suggest a transesophageal echocardiogram based on high peak E velocity. Mean gradient is not too impressive, but still high. Doppler velocity index is high, greater than 2.2. If you have a good ventricle with low systemic output and some pulmonary hypertension. This is Doppler velocity index for the mitral. Is VTI of the jet by CW divided by VTI of the LV outflow tract. Remember, we talked about that. This is not simultaneous, right? So if you have AFib, you gotta be careful about those. Also, in this situation, if I have stenosis of this valve, VTI of the jet is high, so the Doppler velocity index will be elevated in both stenosis as well as regurgitation. Regurgitation, you have high flow coming through, but low systemic output magnifying this ratio. And usually this ratio, and this is for mechanical valves, greater than 2.2 or 2.5. Okay, let's take an example here. You can't tell. I mean, there is rocking motion of the valve, but can you tell how much regurgitation, if there is any? You really can't. Now, if I go further in a different area, which is unusual, I see a major dehiscence here, and I see flow in that dehiscence. And if I do, the measurements, my DVI ratio is 2.7, which is quite excessive, and systemic output is low in this individual. Okay. And if I do further imaging, I think these are beautiful images for you by transesophageal. Take a look at this here. There's a major dehiscence of this prosthesis. Every systole, it just opens up. You could see the hole opening up, that major dehiscence, every systole that, that occurs. So clinical suspicion for significant MR from Doppler should trigger further imaging. And remember, this is mitral valve. So your second best bet is a transesophageal echocardiogram. And in the guidelines, similar to the native valve guidelines, there's an algorithm to help you as to what the significance is. But what we talked about, we use less quantitation of various things with PISA, etc. But I think you understand, that you need to detect it. And the biggest issue by transthoracic is missing it. And this is where also the clinician can help in identifying whether there is an issue with this valve, yes or no, to go ahead and do a further examination with transesophageal. The aortic valve is lesser of an issue since we talked about it. It doesn't hide your regurgitation. It may be tortuous, particularly in a paravalvular area regurgitation. And this is where, these indicators are similar to native aortic regurgitation. However, the frequency of eccentric jets is very high. You got to be careful about that. And TEE will help you identify where's the etiology, what's the mechanism of regurgitation. You could see here, there is a paravalvular dehiscence. There is a small abscess that's starting to show here, and probably early pseudoaneurysm because every systole, it bulges out a little bit in this intervalvular fibrosa. There is also an algorithm for significance of aortic regurgitation by color Doppler. CMR is also very helpful in this situation because particularly for quantitation of regurgitation. So either you use what's called a direct technique. This is for aortic regurgitation, forward flow by phase contrast compared to regurgitant flow, and you can measure regurgitant volume and regurgitant fraction if you want to. If it is mitral, you use the indirect method. You use the total stroke volume from the ventricle and compare that to the systemic output going through the aorta, similar to native mitral regurgitation. CT in those situations is very helpful, particularly when you have significant complications and you want to know the extent of the complication in 3D. Take a look at this case with a pseudoaneurysm. This is the aorta, this is the prosthetic valve. You could see by transesophageal that, there is a major issue. You could see it all around it here, but on a CT examination, you could see the extent of the pseudoaneurysm, so at least it maps the situation for the surgeon to be able to take a look at that and decide what to do down the line. One word about PET is, this is a methodology that nowadays we use from time to time, and it is from time to time only in an infectious situation. PET is usually reserved for endocarditis in case you're really stuck and you really cannot make the diagnosis. Number one, I have a febrile patient with leukocytosis and everything else as prosthetic valve. I do a transesophageal, I can't find a vegetation, and the concern is there something on this valve that I cannot see because you're not 100% accurate? Then you could do a PET scan with FDG looking at uptake in that area. Or another situation where somebody has been on antibiotics, still some febrile, can't see anything, and just wonder whether there's still some infection process there. The second bullet is important because if you just had surgery and within a month or 2 months, there's a febrile illness and you do transesophageal and you can't see anything, you can do a PET, but the PET could be positive just because of the surgical healing and the inflammation that is still occurring. So for you to be specific for an abnormality as opposed to a normality of healing is you have to wait a little longer if you had just recent surgery. And this is a revisiting of the comparison because I think it's important. I divided it for you in two. One we talked about as structure and function, and this one is for regurgitation per se. And if you take a look at regurgitation per se, localization, the best with transesophageal echocardiography, and there's no question. We are very sensitive to even small ones. And there are situations where you need to be sensitive. Somebody comes in with hemolysis, has a small regurgitant jet in the mitral position that is hitting the wall of the atrium and you have hemolysis, you may not be able to detect it by any other methodology. So we can localize it. Valve dehiscence, very good with transesophageal echocardiography, certainly large ones with CT. Endocarditis, always echocardiography is better than any other methodology because particularly if the vegetation is small. Mobile and small, all the others because the time resolution is not as good. For quantitation, yes, you could do quantitation with transesophageal, but probably better quantitation with cardiac MRI. Obviously, we have semi-quantitative approach with echocardiography, but I think the best is probably with MRI if you need to quantitate. So in conclusion, few thoughts for you. One is a clinical evaluation is important. Know the valve type and size and the indication for the study that you're seeing. A baseline echocardiogram with Doppler evaluation after surgery is a must in these patients. There's no question about it. You're going to need it down the line. And nowadays with electronic health records, hopefully you'll be able to see them in other institutions if they come. But I think it's always important to do that. Transthoracic 2D Doppler evaluation of structure and function is the first-line diagnostic method. Main limitation is mechanical mitral valve regurgitation. This is where you will miss it often. And if you detect it, it will be much milder than what it is. So you have to be very sensitive to that and suggest TEE when it's appropriate. Now, advanced imaging, TEE, CT, and CMR provide complementary and valuable information. TEE's impact really depends on the valve type and the position of the valve. The other methodologies are less dependent on where the valve is and what type it is, except mechanical for CMR. CT is particularly helpful in assessing valve anatomy and structure complications, while CMR can provide hemodynamic evaluation and obviously evaluation of remodeling of the ventricle or atria or whatever. And in cases with high gradient and suspected stenosis of regurgitation, few thoughts for you. Always compare with previous studies if they're available. X-ray for mechanical aortic valve prosthesis or question of patient prosthesis mismatch with fluoroscopy. CT with or without NGO is better than TE at this time. TE for other situations, and CT in selected significant complications to see the extent of it or the complexity of the situation. An MRI in some cases of prosthetic valve regurgitation where some quantitation is important or looking at adaptation to the volume overload. And in closing, I want to share with you a picture of some of our colleagues here. You may know some of them at our Imaging Institute, the Baker Heart and Vascular Center. This is Mike Quinones, who's much more fluent in Spanish than I am. This is Sharif Naga, who wrote the guidelines on diastology. Muaz Amalah just finished the American Society of Nuclear Cardiology, the ASNIC presidency. He's really our pet guru. Carla Kurlmeyer, who's the director of our clinic. John Memarian, you heard about in nuclear cardiology. And where's Steve Little? This is Steve Little, who just finished his presidency of the American Society of Echo, and certainly a very, adept at structural heart, prosthetic valves, and interventional echocardiography. Certainly will invite you. Hopefully you can come physically if you're passing by the United States. This is Houston Methodist, the Research Institute adjacent to our hospital. And I invite you to two other things. One, this is how we can connect, although you are in Uruguay, is many of you probably know about our YouTube channel. We have 115,000 followers. For those of you imagers, every Tuesday at noon, it will be live from September all the way to June. So, and you can get them offline. You don't have to be online. You can get them offline while you're exercising or having a good time. And so you can subscribe to our YouTube channel under Debeke Education. And last, I hope I can see you virtually in October. This is our 13th annual multimodality imaging and structural heart. It's on the weekend, a day and a half. The nice thing about it, it's very accessible to you, and the material will be available to you for 2 months afterwards. So hopefully we can connect in so many ways and keep the conversation going. Lastly is a pleasure, and thank you so much for the invitation. And hopefully that has been helpful in your evaluation of prosthetic valves. I'm happy to answer any questions you may have.
Well, first of all, thank you very much for the lecture. It was amazing. So we really appreciate you giving us this lecture for us. It was great. And I want to ask you something about after surgery. When do you think is the optimal time to perform an echocardiogram to have some reference values of gradients after surgery? Because we usually do an echocardiogram during the intervention, and we have some gradients there, but we know they are affected because of the drugs the patient is receiving during surgery. And afterwards, we know the patient sometimes has anemia or tachycardia, and things can vary a lot. So what would you think is the optimal time to have an echocardiogram after surgery?
There is an optimal time and there is a pragmatic time.
Yeah.
The pragmatic time is before they go home. And there is a reason for that. It's not optimal from a hemodynamic and anemia point of view. But as you know, many of these patients have adverse remodeling of the heart. So you want to know if they have an effusion, what's the ventricular function like, what's their PA pressure like, so you can adjust their medications, right? Now, in the worst situation, because of a hyperdynamic situation, the gradients may be higher than what they would be 2 to 3 months later. So yes, you can repeat it 2 to 3 months or a year later if somebody is, so, you have to be cost conscious at the same time in these patients. But I always do one before they go home. So I know how to manage them. And ideally, 2 months down the line, I think would be good.
Perfect. Sebastián?
Yes, I have a question. Which is the best form of quantitation of the paravalvular leak, aortic paravalvular leak with transesophageal?
The
Most
best.
likely, remember, you cannot do much quantitation. You could do semi-quantitation, right?
Yeah.
The semi-quantitation is most likely two things. One is in short axis, you have to take a look at the dehiscence, or what is the shape of the dehiscence in the paravalvular leak. Is it circulate? Is it too large of a crescent? Whatever that area is. So first I take a look at that. Two, if either you have 3D or if you have a good 2D to get it of where the vena contracta, where the smallest area is, you measure the vena contracta area, right?
Yes.
If you measure the vena contracta area. The other thing is if you cannot do that, you could do a long axis and see what is the vena contracta diameter like. The diameter would be okay if the crescent shape of the perivalvular leak is not too large. If it is too large,
shadowing of the valve, because it can be difficult to measure that vena contracta when you have the shadowing of the valve, right?
Exactly. And remember, you have a prosthetic aortic, transthoracic examination and transesophageal complement each other, right? Because on a transthoracic, you can see the leak better anteriorly, and a transesophageal, you see the leak better posteriorly. So you can shadow each other, and that's why you have to take a look at the leaky valve with the two, transthoracic and transesophageal.
And it's more important the size of the dehiscence than the percentage of the circumference.
Yeah. Obviously, if you have dehiscence throughout, there's a problem, right? But if you take a look at our guideline, the 2019,
yeah,
you could have the same vena contracta area, one less circumference than the other, depending on the size. If it is more circular versus more thin and round.
okay.
Basically, it's the size of the hole.
Yeah. Yes. And if you cannot define the significance of the regurgitation, the second option is an MRI.
Yes, there are many ways to look at it. If you have a good transthoracic examination, a good window of the transthoracic examination, You could do regurgitant volume, regurgitant fraction by comparing it to pulmonic or mitral, right? Total output of the ventricle versus the others, right? So you could do that. And if you can't, for whatever reason, MRI will quantitate it. Ultimately, though, remember, ultimately, for you to do something about these regurgitations is what happens to the ventricle and what are the symptoms.
Yes.
These are the two. What happens to the ventricle, size and function, and what are the symptoms?
Yes.
Otherwise,
you're not going to do anything.
And I have another question. What do you think nowadays we're witnessing that a lot of young people are getting bioprosthesis because of avoiding anticoagulation, and valve in valve is an option now. It wasn't a few years later, now it is. How do you see patient prosthesis mismatch is going to be a problem in the future? This is going to affect us in any way?
I do hope, unless there is a major reason to do a bioprosthetic valve very early in life, okay? I do hope that conceivably we could delay such. So I think the age group where people are trying to get bioprosthetic valves is probably about 55 years of age, 60 or 65, right? So remember also, you have to take a look at the overall prognosis of individuals, how healthy they are, what's their ventricle like, what's their coronaries like, what's their comorbidities, because that also determines their overall survival, and say, well, if the survival is rather shorter than somebody who is otherwise very healthy, it's easier to put a bioprosthetic valve in there and do maybe a valve down the line. But if somebody is very healthy, otherwise, ventricle is good, everything else is good, you know that most likely this individual will have a valve replaced again or positioned again rather early. So I think a discussion with patients, I think, is important. But some would be adamant to do that, and then you would do a valve in valve most likely. And and hopefully, when you put that valve, you have a good surgeon to enlarge the aortic root and not put a small valve in.
Yeah.
And these are not easy, meaning if the surgeon is not adapt well to these enlargements, you may end up with complications that are actually worse than just putting a regular valve with some prosthesis mismatch. So you got to be very careful about that.
Okay. Well, Sebastián, do you have any more questions?
No.
Does anyone else have a question? You can do it, put it on the chat. ¿Alguien tiene una pregunta que quiera poner? Well,
this is your chance.
yeah. People are shy here, and more in English.
No, you cannot be shy.
Oh, maybe I can ask something.
Why not?
Yeah.
And when you're evaluating the gradients, in which position do you think the heart rate is something important to be reported? I know it's always important, but is there any position that you think it's most important to report heart rate?
Heart rate is always reported.
Okay.
Period.
I want to hear that.
Blood pressure and heart rate are always reported in our report. Always.
Perfect. I agree. And I think it's important that we do it that way also.
Now, on top of that, in mitral and tricuspid valves, we put the heart rate where we measure the Doppler in the comments.
Perfect.
So that I say valve area is this, mean gradient is this, at a heart rate of this.
Yes.
So people know.
Yes.
Because at times, you can invent a heart rate, but we don't want to invent one.
Mhm.
Yes.
And we have to be to demand our echographists to put all the values we need to interpret as a clinician. We have to demand that, and that's
Certainly,
very important. Yeah.
Because
certainly.
I don't know if you know, but in Uruguay, we don't have sonographers and technicians. TEs and TEs, transthoracic echoes are done by cardiologists. So it's I think there's some
That
pros
may be
about
that may
that.
be good or bad.
Yeah.
That may be good or bad. It is good, okay, because you are the responsible person, right? So whoever is doing it is the responsible person, and they can take it and have an amazing examination. The bad is it takes quite a bit of your time, maybe seeing patients. So it doesn't matter. I don't know how the equation is in Uruguay, but the physician is the only one to blame if they don't do a good job.
There is a
Thank you so
question
much.
here on the chat. It says like, do you recommend 4D flow in resonance, in cardiac resonance, to quantify valvular gradients? We don't have it here, I think, 4D flow, but I think it's something that it's coming. So I don't know if you use it, William, and you have it
Well,
available.
we don't use 4D flow for gradients. I think we use the regular algorithms for that. So
Okay. Well, thank you very much. Thank you for your time. Thank you for your good mood. Like everything you told us, it's like amazing for us. It's a great lecture. We're going to have to look it again to some concepts like I missed, I'm sure. But no, we appreciate it very much, and I'm sure we will wait for you for next Congress or something. We will make everything possible we can to invite you here and to have you.
lovely.
So thank you very much.
Thanks
Thank
again
you
for
so
your
much.
invitation. Have a lovely evening.
Thank
Bye-bye.
you. Nice
Bye-bye.
evening. Gracias
Excelente.
a todos los que se
Bueno,
quedaron
Cami,
hasta esta
excelente.
hora. Los que se conectaron, se quedaron hasta esta hora, todo, la verdad que un éxito, espero que lo hayan disfrutado y bueno, nada, después grabamos esto y lo vamos a mandar para todos, así que bueno, eso. Después tenemos
Dale.
una charla en septiembre, así que ya los invitamos. Es en español, de amiloidosis y bueno, nada, están todos invitados y bienvenidas las ideas, el que quiera acercarse.
Buenísimo.
Besos a
Chao.
todos.
Chao, chao.
Chao, que anden bien.